Hello and good morning, doctor. How are you doing today?
I'm fine. How about you?
Absolutely fantastic. Let's do a website first. And the reason why is because your information today is going to change so many lives that I want people to know right away where can they go to find out more about this.
Also, the website is somalogic.com, SOMALOGIC, all in one word.com.
This is a major first step of a brand new beginning because I had a heart attack at the age of 47. I wish there could have been some warning signs. And it really, I went to a doctor because it felt like I had high blood pressure. He said, mellow out a little bit. And next thing you know, I had a heart attack. But you've got something here that's really going to open up the eyes of a lot of people who could be in trouble.
Yeah, well, the interesting thing about your case is because you've had a heart attack in the past, you're permanently labeled at high risk.
Mm-hmm.
And you're probably, well, hopefully, you're doing all the necessary lifestyle changes and you're on different medications to prevent the next one.
Yes.
But the problem, and you can tell me if I'm right or not, the problem you face is it enough? Did I control the risk or am I still carrying around some unresolved residual risk? Do I need to do more? Or am I back to normal? And so one of the reasons we started looking at cardiovascular risk was because there are people like you who need to know whether you're going to have another event or not, need to know whether they need more intensive treatment or not. And yet the existing risk scores, which are typically based on your medical history, age, sex, race, and of course your control of blood pressure and cholesterol, but they're loaded up with these factors, these immutable factors that you can't change. You can't change your sex or your age or your medical history, but you can change your risk. It might have got worse if you started smoking, and it might have got better if you're fully compliant with the guidelines. Or it might not be enough. You might need to take an extra cardioprotective drug. So that was where we started. We started looking at what are the shortcomings of existing risk scores, and could proteomics actually solve that problem?
I live with this every day. You're absolutely right when you say that fear, because as much as I am taking the right meds, and if the BP goes up a little bit, I know what I'm supposed to do, but you still wonder, is it going to happen tonight when I go to sleep? I mean, and you hope that, if it does happen, I hope it's peaceful and that that it's not drug out.
Yeah, I mean, the consequences of an event can be, if you survive it, they can still be highly negative.
Yeah.
So we started there with looking at, well, what are the conditions where interventions exist, but there's a risk assessment problem that if you only knew, could you be more efficient at allocating medicines? And it affects people like yourself who've had an event in the past. But that same problem, the fact that risk scores don't work very well, exists for people who have diabetes or people who are elderly or people who have kidney disease. So those are the conditions where we started looking for protein patterns that could do a better job at predicting future outcomes, and things that would change, they would improve if you did good things, and they would get worse if you did bad things.
I was going to ask you about protein because, the protein seems to be a major part of the research that's going involved in this. So you're saying that protein from other areas of the body need to get to work, basically.
Yeah, the proteins are telling us about the systems, the biological systems in your body, whether it's inflammation, or are you building new blood vessels, or is your blood clotting too much? Those kinds of things. They're active systems that are interacting all the time in your body. And the nice thing about proteomics, which is where you measure thousands of those proteins at once, is you cast a wide net to interrogate those systems and look for patterns that can be more predictive than any one protein on its own. Because, of course, you probably go to the doctor and you probably have a protein measured. You might have your CRP measured.
That's it.
And the problem with one protein at a time is that they're not very unique to a particular risk, and they're not very predictive. But the patterns, I like to say that proteomics is like tapping into the body's internet. But actually, protein network patterns have evolved to transmit information. Proteins are the downstream targets of 95% of all known drugs. downstream to your genetic blueprint, which it sounds like you may have had an unlucky genetic blueprint, but also the environment that you're in. It might be a good environment in that you're taking your statins and your blood pressure control and your aspirin, but it might be a bad environment in that you're smoking or you're morbidly obese. So proteins are downstream to all of those things. And so when you go interrogating, using machine learning, interrogating those patterns to find the system effects that are the best predictors of these events, you're creating a search engine into the body's internet. You're looking for a particular pattern that is the best predictor of the risk of future events. And that's what we did with this test and what we've done with the 17 other tests that we have.
For people who have suffered heart attacks, strokes, and or could be in fear of it, is this something that a test that you can get from the regular family doctor, or do they need to see a cardiologist to have a real hardcore test like this?
That is the vision, that it will end up being widely accessible to everybody that needs it. We do think that primary care doctors, that the result is pretty simple to interpret. There are different risk categories and an absolute likelihood score. So the vision is that family doctors will be able to interpret it. And in fact, we are working with a number of concierge practices today who are doing exactly that, engaging in preventative health discussions with their patients. And we're working with 3 health systems, University of Colorado Health, University Hospitals Cleveland and Emory. And the vision is that, yes, it's democratized, it's broadly available, and we're in the process of building up that access. But today, it's not quite there.
Mm-hmm. When diagnosed, you talk about playing the game of what if. What if you're diagnosed? Is it a change in your lifestyle, or do you start preparing?
Oh, certainly for cardiovascular risk, there are lots of things you can do. We've shown that this risk score goes down with diet and exercise.
Yes.
It gets worse with COVID. It gets worse with chemotherapy. It gets worse as people approach an event. It gets worse with smoking, but it also gets better with other cardioprotective drugs. We think it's nicely sensitive to what you're doing, and lifestyle and pharmacology, drugs can be used in combination to change these things.
Do you think we'll ever move away from the days of the statins, only because there are millions of people globally that are affected by statins in the way of the body aches? And I mean, because statins, yes, they're beautiful for the body, but the body is, oh my God, it's in so much pain.
Yeah, and you're right. In some respects, statins are a miracle drug, and they've saved millions of lives. But what do people do who can't tolerate them? Well, of course, you can control blood pressure and cholesterol in other ways. But there's also, if people are not, people like you, let's say you had an event in the past, but you can't tolerate a statin today. Actually, running the blood test would tell you whether you need to add something or not. And so if you're not taking something today, but you're, say, in our low-risk category, maybe because of other things you've done, like controlling your blood pressure or whatever other things, if you're in the low-risk category, you and your physician might decide that actually that's okay. But if you're not in the low-risk category, then maybe you'd go on a PCSK9 drug or a SGLT2 inhibitor or a GLP-1. So there are other interventions that are not statins, but actually informing people as to how bad their risk actually is an important step on the way.
Once again, this is so mind-blowing and so in touch with where we need to be today. So now the thing is, though, now how does the average person participate? I know that here in Charlotte we have a lot of research teams and stuff like that. Do people volunteer to research so you guys can get more information? How is it that we can help play into this to make sure that this becomes a reality on all levels?
That's a great question. A lot of people who are developing new drugs, a lot of researchers developing new drugs are using this technology to look at, the fingerprint of those drugs. Are they safe? Are they effective? Are they causing off-target, unwanted effects like the ones you mentioned for statins? So joining clinical trials of new products, is an important contribution, I think, to the future health of society. I'd like to say that people could get the test from their doctors today, but they can't quite.
Right.
As I said earlier, we're really looking forward to expanding the access to everybody that needs a test like this, and not just this test, but the other tests that are also protein patterns. So what your kidneys are likely to do in the future, not just what's happening today, but are they on a bad trajectory if you've got diabetes? What's happening in your liver? Has it got liver fat, or is it fibrosing?
Yep.
What's happening with your insulin resistance, and your body composition, your visceral fat? All of those things can actually be determined from the pattern of proteins in your blood all at once. So think about this as we called it in one of the publications, the liquid health check, that actually, in theory, this enables a kind of distributed health model that could be more comprehensive than any physician could accomplish in a typical examination. So when I look forward to the vision for the future, it's really that democratization and distribution of health that doesn't depend on a physician having the time and the skills to do all of that for an individual patient when the demands on their time are huge and they might just have a few minutes. If they could be informed about all the systems and all the health issues, the current health states and future risks that an individual is facing, then that would enable physicians to be to claim back some of their time and turn it into a discussion of what do we do about this, rather than I wonder what's going wrong.
I'm so grateful for your dedication and loyalty. I really am. And I look forward to talking to you many more times in the future as you continue to grow this forward.
Great. It's been a pleasure. Thank you.
Please come back to this show anytime, okay?
Great.
You be brilliant today, okay, Doctor?
Well, thank you, Ara.